getting their arm out straight, transfers, doing their activities of daily living, maybe having a helping hand where they wouldn't otherwise.
You know, to me, it's just fascinating.
Well, many people, as we talked about strokes, develop spasticity, and that's really because of the neurologic injury they have to the upper brain centers. And it's basically an overpowering response to stretch of muscles. And it causes certain postures in certain injuries, certain brain injuries, whether it's a brain injury from trauma or whether it's a stroke. And those patterns are often more of a flexor pattern. For example, in the upper extremity, it's often a bent elbow, bent wrist, and tight fingers. Now, physical therapy is really the mainstay of that treatment, stretching out, reducing the spasticity. We have oral medications that often help. And people evolve through certain amounts of the spasticity. Botox is really a purified toxin, botulinum toxin. Many people may remember botulism, where the can was expanded and your mother told you not to
Don't eat
that food. But it's been purified and gone through many, many cycles of safety testing. It's one of the safest drugs there is. And basically in the 1980s, it was FDA approved for certain indications around the eyes, people that had constant blinking, eye muscle imbalance. We started injecting it in the larger muscles for spasticity. That's an off-label usage. However, the FDA just came out last week and approved it for upper extremity spastic muscles. But the whole purpose of it, botulism would paralyze someone. So we inject certain muscles that are over-pulling spastically and partially paralyze the muscle, weaken it, so other muscles that could possibly be recruited to function can function. We don't bring back muscles that aren't working. We just release the tight muscles. But sometimes that's very helpful in someone getting dressed.
I have a friend that you've helped who has cerebral palsy, and you've been injecting her, she told me, and
yes,
and it's been such a help to her. So you know, here we hear about Botox for cosmetic purposes,
right?
But it's good to see that it's being used for something that really is helping people.
Right, and it really is a standard of care in rehabilitation of stroke patients, cerebral palsy patients, multiple sclerosis patients, anyone who develops spasticity. It is also helpful in dystonias, which is another type of overfiring muscle mechanism, neuromuscular mechanism. Most often in cervical dystonia, people that head tilt a little bit, we can relax those muscles. And writer's cramp is actually a dystonia. So we have had some patients that would write for us. We would isolate which muscles were most in play. We would inject those muscles and then have them back in a month to see how they were writing. And most of them were improved.
To me, that's fascinating. Do you have people who come in and want to know if they're going to get botulism if you inject them?
Yes. As a matter of fact, there are some very specific permissions we have to get from patients to give this. There have been probably about 30 deaths associated with Botox.
Had no idea.
Yeah, but we're not clear if the Botox was the prime cause of the death. These were often maybe young children, cerebral palsy with high doses of medicine, people injected around the neck, and it affected some of the swallowing muscles. Then they may have had an aspiration or a pneumonia as a result. But there are only 30 worldwide or thereabouts of, you know, probably 10 million injections done cosmetically. So we use a safe dose, safe location, and fortunately we haven't had any significant problems.
That's good to know. I mean, and those numbers are very small in comparison to the numbers that are being done. You brought some pictures with you?
I did.
Okay, Phil, if you'll put the pictures up on the screen, please, Dr. Dunstan will tell us what they are.
Yeah, the first picture is Dr. Andrea Stutzman, who runs our work recovery program and our cancer rehabilitation program. And here she's working with a worker, discussing return to work issues, and that she's the expert at that. She essentially runs a boot camp for workers that aren't quite back to good function, kind of identifies motivational issues, barriers to their return to work, and does intensive therapy with our therapists to help those people recover, get back to work, and make sure they can do it safely.
All right, Bill, there you go.
Here I'm examining a patient, really just examining the hand for tightness of the flexor tendons. And again, this was a patient who was a Botox patient. So we were just seeing him in physical therapy. Our physical therapy clinic is right across the hall from where our Botox clinic is. So it's very easy to bounce over and see a patient as they recover if they're having any issues.
Now, is that at Central Health?
Right. Both are at the Virginia Baptist.
Okay.
Here I'm talking to our nurse manager who ran acute rehab unit when I was down there. And we're just comparing notes on various patients and various therapies. And acute rehab is probably our most intense rehabilitation area in the hospital. It's for patients that need acute care but can tolerate up to 3 hours of therapy a day, but still require rehabilitative nursing care and daily visits from their physician. So it's a real balancing act. Is someone too sick for this unit, or, you know, what can they do? So it's our most intense unit, so we stress the patients a lot, but this is really where we see our most rapid recovery in their activities of daily living. And it really makes a difference sometimes between someone going to a long-term care facility or going home.
And with this nurse, it's really a team effort.
Absolutely. We have on acute rehab interdisciplinary team meetings,
Right.
And we all work together and appreciate each other's input for the best of the patient. Now, a year and a half ago, Dr. James Stutzman came and replaced me on acute rehab. And we take stroke patients, we take debilitated patients, cardiac patients, anyone who really needs intensive therapy and can profit from it and make gains.
Do you sit in on the interdisciplinary meetings?
I don't.
Didn't know
There
if you
is
did.
a medical director of each of our skilled facilities as well, and they participate in the interdisciplinary team meetings. I kind of work as a consultant at the skilled facilities. This is showing another problem more with cardiac patients or patients that need to build up endurance. Stacy Pedigo is an occupational therapist, and this is an ergometer, which, if you've ever tried one, wears you out pretty quickly. And but it really works on your upper extremity energy, range of motion, strength, and it's a good way to burn calories and build up your endurance. This is really just Stacy with another patient and another view of the same machine. You know, one of the things that has really been emphasized in therapy now is core strengthening, balance issues. A lot of patients with strokes or other debilities have balance issues. People with who had a joint replacement, they're not used to walking in a certain fashion. They need to learn assistive devices safely. And the last thing you want is one of these patients to fall. So we're always working on balance issues, core training, and safety. This is just the logo of our STAR program, which is Survivorship Training and Rehab. An acronym is STAR. And this was really started by my first meeting, Julie Silver, who was a physiatrist and professor of physical medicine and rehab at Harvard. And I met her actually at a writing course. And she came down and gave a talk to our group, and she's a cancer survivor herself. And she said that was something missing in her recovery. And so she started a national program, the STAR Survivorship Training. And because of contacts with Lynchburg that were very positive with our whole division, she decided to make us a test site, and then we passed all the cancer-specific therapy learning modules, and then we were certified as the first STAR program in the country.
And that's the oncology rehab program.
That's the oncology rehab, and now one's being developed at Johns Hopkins and other facilities. But we were really the first.
We'll come back and talk about that after we get through the pictures. I think that's interesting.